We have Dr. Jean-François Boileau, who is an associate professor in the Department of Surgery and Oncology at McGill University. He's currently the head of the Jewish General Hospital Breast Clinical Trials Group and is also an author on several breast studies such as the Palette and the Christine trials. He's also the principal investigator of the Sentinel lymph node FNAC study, which has helped to establish Sentinel lymph node biopsy as a method to restage the axilla after node-positive breast cancer patients after neoadjuvant chemotherapy. So we'd like to invite Dr. Boileau to share with us about axillary surgery for breast cancer going forward.
Hello, my name is Jean-François Boileau. I'm a surgical oncologist at McGill University in Montreal. I'd like to thank the organizers for inviting me to present at the NCIS International Surgical Oncology Symposium this year. I'll be presenting on the axillary surgery for breast cancer the next decade. Here are my disclosures. So today's presentation will discuss the brief history of axillary surgery for breast cancer. We'll discuss recent advances that will impact how we'll manage the axilla in the next 10 years. We'll discuss if we still need to perform axillary staging in the era of precision medicine. And we'll talk about new trials and concepts that will help us evolve our knowledge of axillary management in the future. And during the presentation, if you see the little sunshine on the slide, this means this is new updated data from the past year. So learning about the past will help us better understand the future. Initially, axillary staging was part of Halsted's radical mastectomy. The reason why such a surgery was promoted is because of the theory that cancer progression was done by direct extension. So it was normal that local regional management with expansive surgeries were recommended in order to halt the progression of the disease. This theory held true until the 1970s, where Bernard Fisher brought the alternative hypothesis. Now, this hypothesis stipulated that operable breast cancer is a systemic disease and that variations in local regional therapy were unlikely to affect survival of breast cancer patients. But also very importantly, the idea was to test new hypotheses using randomized controlled trials. In the NSABP, in their first surgical trial, the B04 trial, had evaluated in patients with clinically node-negative disease, Halsted radical mastectomy versus only performing a total mastectomy versus total mastectomy and radiation therapy. Now, in patients that were node-positive, the comparison was with radical mastectomy and total mastectomy and radiation therapy. So in effect, for the axilla, at least in patients with clinically node-negative disease, this was a direct comparison of axillary node dissection versus no axillary treatment at all versus radiation therapy. And although the survival was the same in all the different subgroups, what was interesting to note is that for patients that did not have any axillary therapy, there was an axillary recurrence rate of 18.6%, which was thought to not be acceptable. The other information we learned from the B04 trial was that axillary node dissection was equal to axillary radiation therapy. Now, in future surgical trials from the NSABP, the standard management that was chosen for the axilla was axillary node dissection. Now, from the data from B04, it could have been axillary radiation therapy, but node dissection became the standard. So we'll fast forward to the future, and for many years, we were treating breast cancer patients in a standard fashion with an axillary node dissection. But as you know, axillary node dissection has significant morbidity. And in order to decrease this morbidity, sentinel node biopsy appeared as a new standard treatment for patients that had clinically negative axillas. Now, sentinel node biopsy, when a node is positive, the next step was to try to see if we could avoid completion node dissection in these patients. And as you know, there are three trials that have guided our decision processes for these patients with positive sentinel node. The ACOSOG Z11 trial, the AMAROS trial, and the IBCS G2301 trial. Now, the take-home message from these three trials is that most patients with 1 to 3 sentinel nodes positive can safely avoid node dissection. Now, if a patient has 1 or 2 sentinel node positives and gets breast conserving surgery, theoretically, you could just do whole breast radiation therapy and no need to complete the node dissection for most of these patients. And if there's 3 nodes positive, the patient needs a mastectomy, or if there's significant extracapsular extension, then the AMAROS trial has taught us that by giving axillary radiation therapy instead of surgery, we can have the same oncological outcome with half the morbidity. And the IBCS G2301 trial has taught us that with micrometastases in the axilla, we do not need to give axillary radiation therapy or completion node dissection. Now, recently at the San Antonio meeting in 2020, there was a trial that was presented which represents in some way a Z11 update. And it is the SINODAR-1 trial that was presented by Tinteri colleagues. So, as you know, in the ACOSOG Z11, the prognosis of many patients in that trial was excellent, and there was about 40% of patients that had only micrometastases. And in the SINODAR-1 trial, which was the same methodology as the Z11 trial, they had 100% of patients who had macrometastases. So it was interesting to see that their outcome was excellent, very similar to what was seen in the Z11 trial. So this is reassuring to tell us that our current practice in using sentinel node biopsy only for patients with limited axillary disease is safe. What was also interesting in the SINODAR-1 trial is that there were 20% of patients that had mastectomies. And a lot of us have extrapolated the Z11 data to patients having mastectomies. Now, the follow-up is very short at 2.5 years, especially for estrogen-positive patients. So longer follow-up is needed of this trial to confirm these findings, and we need more events to happen on the trial. So next, we'll talk about the management of the axilla after neoadjuvant therapy. So this has evolved very rapidly in the last couple of years. So neoadjuvant therapy has become a standard treatment for many of our breast cancer patients, especially patients with higher risk or highly chemosensitive tumors, which are triple negative and HER2 positive. The main reason is that when we treat these patients with neoadjuvant therapy and they have residual disease, we have some effective systemic therapy to offer them. We also know that these patients have a very high rate of having a complete response in the axilla. Now, for patients that present with clinically node-negative disease, restaging the axilla or staging the axilla with sentinel node biopsy is a well-established and accepted procedure. The technical success rate is very high and the false negative rate low. So this is not controversial. But in patients that present with node-positive disease, restaging the axilla after neoadjuvant therapy has been the subject of many trials. So there was a German trial, an American trial, Canadian trial, and the French trial, which have all basically evaluated the same accuracy of sentinel node biopsy in those node-positive patients following neoadjuvant therapy. And the cutoff that was deemed acceptable was a false negative rate of 10%. Now, most of these trials did not meet their primary endpoint, and the false negative rate was slightly higher than 10%. So many of the groups have tried to look at ways to be able to lower that false negative rate. And we know that when we use dual tracers, so blue dye and radioisotope, or if we harvest sometimes more than 2, sometimes 2 or more, sometimes 3 or more nodes, or if we use immunohistochemistry and identify these patients with node-positive disease as being as having positive nodes, those are all techniques that we can use to lower the false negative rate less than 10%. Now, investigators have tried to find other means of improving the accuracy for these patients, and one of the tools that was investigated was the use of an ultrasound following neoadjuvant therapy prior to surgery to identify patients with suspicious nodes in which we would not offer a sentinel node biopsy. And by doing so, we are able to lower the false negative rate to less than 10%. This was shown in the Canadian SNFNAC trial, as well as the ACOSOG 1071 trial. But the problem is that by using an ultrasound and prohibiting patients in getting a sentinel node biopsy assessment, we're also increasing the number of unnecessary axillary node dissection. And in this study, it was shown that 28% of patients with a positive ultrasound after neoadjuvant therapy actually have achieved a complete response at the time of surgery. So this is not the best tool to use. There is a technique that's far more interesting, which is actually marking the positive node at the time of biopsy and harvesting that node at the time of surgery. And when coupled with a sentinel node biopsy, this is called a targeted axillary dissection. And the first group to describe this was a group from MD Anderson. It was interesting to see that they could lower their false negative rate from 10% to 2% just by adding the removal of this marked node. Also interesting, 23% of the time, the clip node was not a sentinel node. But as you can see here, this clip node that was not a sentinel node was the only positive node in only 4% of patients. This is why we can still have a certain accuracy without removing the marked node, but it is definitely more favorable, more accurate when both techniques are used at the same time. So here is presented the data from the Mary procedure. So the Mary procedure is actually only the removal of the marked node without a sentinel node biopsy. And this Dutch group has actually positioned the radioactive seed at the beginning, at the time of biopsy, prior to neoadjuvant therapy. And then they only harvested that node once surgery was done after the therapy. And by doing this harvesting of the clip node alone, they were able to achieve a false negative rate of 7%, which is very interesting. But at San Antonio in 2020, another Dutch group presented the RESUS method, which is actually the removal of the clip node following the Mary procedure and the addition of a sentinel node biopsy. And by using the dual technique, as was identified in the TAD data from MD Anderson, the false negative rate observed was very low at 3.5%. And again, the clip node was not a sentinel node in a high number of patients, in this case, 28.7%. So if we put all of this data together, even though we can obtain an acceptable accuracy by optimizing sentinel node biopsy or only removing the clip node, certainly using both sentinel node biopsy and the removal of the clip node can lower the false negative rate to a very low 2 to 4%. Now, this is very important because, as you know, identifying patients with residual disease, we now have effective systemic therapies that can improve their long-term outcome, especially for patients that are triple negative or HER2 positive. So it's very important that we optimize the technique to identify the non-responders. So here is presented a paper from Eva Kwong, who has shown that by using the clipped node method, so clipping the node at the time of biopsy and then placing either a seed or a wire to remove the node at time of surgery, there is a certain technical failure rate, and it's about 12%. So there was success in 88% of patients. Now, when radioactive seeds were used, the technical success rate was a little bit higher. But it was interesting because she showed 4 papers that have actually looked at tattooing the node. And tattooing the node is interesting because we don't need to have a facility with nuclear medicine, and we don't need to go through the complexities of installing a radioactive seed program. And just by tattooing the node at the time of the biopsy and identifying that tattooed node and removing it after neoadjuvant therapy, they had a technical success rate of 97%. So a very approachable and quite effective method of marking and removing the marked node. Now, still, many do not consider removal of the marked node as a standard. This is a study that was presented by Weiss at San Antonio in 2020, where of the 74 patients that had clipped nodes and sentinel node removed, they only had found one patient in which the clipped node was not a sentinel node and was also positive. So for an additional benefit of 1.4% for these patients by clipping the node and harvesting that node. So it is still a controversial subject. Now, for people contemplating using this method of restaging the axilla for node-positive patients after neoadjuvant therapy, the common question is, what is the local regional recurrence of these patients long-term? And actually, interesting, again at San Antonio in 2020, Boileau and al. Presented their cohort of 770 patients who had restaging of their axilla after neoadjuvant therapy, and there was only 1 out of 234 axillary recurrences at 35 months, for an axillary recurrence rate of 0.4%. So this is quite reassuring for those of us who are currently applying this to our patients. Now, the use of sentinel node biopsy to restage the axilla after neoadjuvant therapy in node-positive patients is endorsed by the Segal consensus and by the NCCN guidelines. I won't go over these again, but these are the criteria that we currently use to select patients for restaging of the axilla with sentinel node biopsy. A common question that we have is, when we use neoadjuvant endocrine therapy, can we just copy paste and apply those criteria that we use for patients that are receiving neoadjuvant chemotherapy? Well, actually, PCR is a very rare event for patients that are ER positive getting neoadjuvant endocrine therapy, even in trials in which we've added CDK4/6 inhibitors. The axillary PCR rate will be between 3 and 4%. So what we currently do is we tend to extrapolate the criteria that we use from the Z11 trial and the Amoros trial for these patients, and basically manage their axilla as if they weren't receiving any neoadjuvant endocrine therapy. Now, certainly this is a controversial topic and needs to be further studied before conclusive evidence guides our practice. One of the common questions we have is it still necessary to stage the axilla in the era of precision medicine? And you all are aware of the TAILOR-X trial that has established the recurrence score as a good method to identify patients that benefit from chemotherapy, and those are in node-negative patients. But the data was recently presented at San Antonio, was the RxPonder trial. And the RxPonder trial was in patients with 1 to 3 nodes positive, which had a recurrence score between 0 and 25, either pre or postmenopausal, were then randomized to chemotherapy and endocrine therapy versus endocrine therapy alone. And what we learned is that in postmenopausal women that have scores between 0 and 25, there is no benefit of chemotherapy. So theoretically, one would be very certain that there would be limited nodal burden or not in the axilla, one could envision just using the recurrence score and deciding for systemic therapy and not needing axillary staging at all. That might become something that we will use with different algorithms or patient selection in the future for postmenopausal women. But for the time being, what the RxPonder has clearly showed to us is that premenopausal women with node-positive disease benefit from chemotherapy regardless of the recurrence score. So in the premenopausal woman, axillary staging is absolutely essential in order to determine if this patient needs chemotherapy. The chemotherapy benefit for node-positive premenopausal women was both significant for invasive disease-free survival, distant recurrence, but also overall survival, which was statistically significant. And interestingly, the hazards ratio was similar, if anything, even better for the lower recurrence score, although the absolute benefit of chemotherapy was smaller in the group with recurrence scores 0 to 13. And we will need the publication to be able to dwell into the details of the different lower recurrence score subgroups of premenopausal women to see if there are some people in which we could avoid chemotherapy. And the other big question out there is, can some of the benefit of chemotherapy be replaced by ovarian suppression? But certainly for the time being, nodal staging in premenopausal women is essential, even to identify those patients that might benefit from ovarian suppression with higher risk disease. And again, in the future, we will have the results of an ongoing trial, which is the SOUND trial, which is basically identifying a very good prognosis subgroup of patients in which we might actually avoid axillary staging altogether. So those are patients with tumors 2 centimeters or less who have a negative axilla, or if they've had an ultrasound and have found a suspicious node, they have to have a negative biopsy of that node, and they're randomized to sentinel node evaluation versus no axillary staging at all. And certainly that's going to be quite informative on maybe a method in these postmenopausal women to then not need any axillary staging at all in the future. So we're awaiting those results. Now, I haven't spent a lot of time discussing premenopausal, elderly population of patients in which we might avoid axillary staging. And there exist some guidelines, the Choose Wisely guidelines, which inform us to not routinely use sentinel node biopsy in clinically node-negative women that are more than 70 years old. Now, we know that this is somewhat controversial because we do have other sets of data that show breast cancer-specific mortality being worse in the elderly population, possibly due to undertreatment. So we always have to make an informed decision, an enlightened decision based on patients' life expectancy, comorbidities, etc. But certainly what we do know is that right now, sentinel node biopsy is being performed in more than 80% of this patient's cohort. So there's probably overutilization of axillary staging in those patients. And this was the topic of one of the studies presented at San Antonio, again, by a Canadian group from British Columbia. And what Dr. McKevitt and colleagues presented was that in the elderly population, when using a sentinel node biopsy, we tend to increase the use of chemotherapy added to endocrine therapy in that subgroup of patients. They also have shown that by using sentinel node biopsy and staging the nodes and identifying more patients with positive nodes, we increase the use of nodal radiation therapy. Now, in a multivariate analysis, what was interesting is that they did not show that breast cancer-specific survival was impacted by neither the use of chemotherapy or radiation therapy. Now, chemotherapy is not so surprising because, as we've learned from the responder data in postmenopausal women, actually most patients don't benefit from chemotherapy. And it would have been interesting to have disease-free survival or local recurrence rates for the use of radiation therapy, especially in patients with sentinel nodes that are positive, and even more granular, the benefit of nodal radiation therapy. That would have been interesting information. But in their multivariate analysis, it seems that only the use of endocrine therapy seemed to improve breast cancer-specific survival for these patients. So it does support the Choose Wisely guidelines that we probably should not be using routinely axillary staging in all elderly patients. In the future, what to expect with regards to ongoing clinical trials and results that will be provided to us in the following years. Certainly there are trials of de-escalating surgery, and the Alliance 11-202 trial is an important one. This is a trial for patients with node-positive disease undergoing neoadjuvant therapy, staging of their axilla with sentinel node, and they have positive nodes, and they're randomized to either an axillary node dissection or axillary radiation therapy. So in some ways, it's like the AMAROS trial being done post-neoadjuvant for patients with node-positive disease. And if this trial shows equivalency between the two treatments, then certainly we might have another option for these patients and descaling further completion node dissections for these patients. Now, about patients that have node-positive disease and that are ER positive. As we know, these patients will very rarely achieve an axillary complete response. And also now with the RxPonder trial, we've learned that many of these patients don't even need chemotherapy at all. So neoadjuvant therapy is not the optimal treatment for these patients. And if we look at the NCCN guidelines, since 2019, it was indicated that for patients that would otherwise follow the Z11 criteria, if they had a clinically negative axilla and had a biopsy-proven node in the axilla, often with only 1 or 2 suspicious nodes on ultrasound, it was reasonable to offer a sentinel node biopsy to these patients. Now, the other option would be to play ostrich, not go and look in the axilla, and then just stage the axilla with a sentinel biopsy. But as you can see, it would be the same management that would be chosen for these patients. Now, this is part of the NCCN guidelines, but there's actually very little data to support this, because these patients were actually excluded from the Z11, the AMAROS, and the IBCSG trials. So because of this, we're currently conducting the TADN trial in Canada, where we're evaluating these patients in a prospective manner. And actually, we're adding the removal of the marked node, the targeted marked node, at the same time as sentinel biopsy, so performing a targeted axillary dissection in these patients and evaluating the clinical benefit of these different procedures. Now, there are trials of de-escalation of radiation therapy, and one of this trial is the NSABP-B51 trial, in which patients with node-positive disease that receive neoadjuvant therapy and that become node-negative are randomized to either regional node radiation therapy or no regional node radiation therapy. So then again, if this trial shows that there's no benefit of radiation therapy, this might have an impact, and we might choose our regional radiation therapy management based on the post-neoadjuvant status of the axilla. Now, I didn't discuss the trials of either ongoing or future trials with novel surgical techniques because of time, but there are some very interesting trials and even techniques being used now with regards to new localization techniques for the breast or the nodes, novel mapping techniques, and even interventional ablation techniques. So in conclusion, de-escalating axillary surgery in the treatment of breast cancer is not new. It was part of the first randomized controlled surgical trial for breast cancer. Sentinel node biopsy is currently the standard for our patients with clinically negative axillas. And for most patients with 1 to 3 positive sentinel nodes, we can safely avoid completion node dissection. Now, if a patient has a clinically negative axilla and 1 or 2 suspicious nodes on ultrasound, they can be offered staging with sentinel node biopsy. Now, the most accurate method to restage the axilla of node-positive patients after neoadjuvant therapy is by using the dual technique of sentinel node biopsy plus removal of the marked node that was marked at the time of the biopsy. Now, axillary staging remains important for the local regional treatment of most patients. And in premenopausal women is essential to evaluate their need for systemic therapy or modulations of the systemic therapy. Now, in the elderly population, avoidance of axillary staging is an option for many patients. And ongoing trials will inform us on the safety of further de-escalating regional therapy in an increasing number of selected patients. So I thank you very much for your attention.
Thank you very much, Dr. Boileau. We'll now open the floor for any questions. Yeah.
Thank you for that very nice talk again.
Thank you.
Yep, just wanted to ask, because I'm actually an upper GI surgeon, I don't do breast cancer surgery in general. But for gastric cancer, at least, we have been increasingly using fluorescence marker, ICG, to help with lymph node dissection during gastrectomy. Just wanted to ask you as well, because a lot of the limitation of tracers, like the dual tracer that breast surgeons use, or ICG, is that it's not cancer specific. Is there anything ongoing or being developed with regards to finding a cancer specific marker to help us identify lymph nodes that are positive?
Actually, the ICG techniques are currently being used in many centers in breast cancer as well, and it actually is very accurate. And people have successfully replaced other tracers, either the standard blue tracers or even the radioisotopes with the ICG techniques. So they're as you've mentioned, I think they're effective in many different cancers because they follow the lymphatics well, but certainly have been proven to be quite effective in breast cancer. And it's nice because it's a technique that doesn't require having to deal with radiation oncology, so quite accessible.
Yeah, but I find that the ICG is also not cancer specific. It means it goes to all the lymph nodes in that basin. Any work being done on a cancer specific marker for the future?
Yeah, so, well, the limitations of the ICG in the axilla, and I'm just talking about the breast arena here, is often has to do with the depth. Because we do these surgeries in the axilla, especially in patients that are a little bit bigger, sometimes to be able to obtain the nodes that are deeper is sometimes a little bit more difficult. So you might need to proceed with more exposure in the axilla. And one of the limitations that exists as well is if surgeons sometimes are not careful mapping the lymphatics very well, they can have some leakage. And certainly in the breast arena, it's been one of the problems with the ICG technique. So every technique has their own limitations. That's certainly one with the ICG in breast.
Thank you.
I have another question. My disclaimer is that I'm also not a breast surgeon. But similar, I guess, to our patients with melanoma, we are also moving away from doing completion lymph node dissections for patients with positive nodes. In this case, for those who are clinically node positive prior to neoadjuvant and subsequently are found to have negative sentinel nodes, how often do you survey these patients, and what imaging modality do you use?
We actually don't recommend any specific modality because the axillary recurrence rates are so low. We're talking about 1%. Yeah. So the incidence is so rare that we will only use clinical evaluation. And usually we follow our patients about every 6 months for 2 years, and then we'll rapidly see them every year. Local regional recurrences is becoming a very rare event in breast cancer, and that's why we can do that. Yeah. Some people have used ultrasounds in their follow-up, but most centers do not.
Right. So similarly, you don't find that anyway, because the recurrences are so low that they don't affect the overall recurrence. And anyway, you have really good options for systemic treatments for your breast cancer patients.
Yeah, we're lucky for that.
Yeah.
The endocrine therapy and the radiation therapy control the remaining disease. As maybe you know from the Z11 trial, we know that by doing sentinel node biopsy in patients that are, let's say, node positive, you can leave 20%, 25% of patients with residual nodal disease in their axilla, and yet their disease will be well controlled with the adjuvant treatments. So that's That's one of the characteristics of breast cancer that had facilitated the de-escalation of surgical management, certainly.
Okay, I think if we have no other questions, thank you very much, Dr. Boileau, for the very comprehensive
Thank
talk.
you very much.
Yep.